together, I think we can start to at least contemplate and think about the potential to cure myeloma or to have cures for some types of myeloma in our lifetime, which is pretty phenomenal. I mean, that would be unthinkable 5 years ago. So Rafat's going to take us through his vision on how to cure myeloma, and you're very, very welcome, Rafat. Thank you for making the trip over.
Thank you. Thank you. Well, good evening. Thank you for allowing me to come here and talk about curing multiple myeloma. Take a bold guy to say that, I think, so literally. And a lot of my colleagues, I just tweeted that I'm here, and they said, "Are you staying in London, after what happened last week?" I don't know if it's any better, but we'll see. So I'm going to try to go over in the next 35 minutes or so to talk about how we're going to overcome multiple myeloma. So the first thing really is to understand how myeloma cells survive, what is the nature of the originating cells, and understand what we call clonal heterogeneity. Myeloma cells are not created equally. And then maybe touch on the value of minimal residual disease and briefly touch on the importance of patient immune surveillance. So you're all aware of, that myeloma cells really depends on the stroma and the environment within the bone marrow to grow. And some of the work that was done here in England really sort of highlight that, for example, inhibiting osteoclast activity using bisphosphonate does improve overall survival. So that was a hint that, interfering with this vicious cycles within the bone marrow, really important for inhibiting the growth of myeloma cells. And many of the drugs we're using today work on reducing the production of such cytokines that are important for this interaction between the plasma and the stroma. The other things you are familiar with is this originating cells. The myeloma stem cells, so-called, tend to be sort of dormant, very drug resistant, and usually spends off myeloma cells. So when we try to use a treatment program, we need to also pay attention to these residual myeloma stem cells. And then you've seen this before, the issue of clonal heterogeneity and the dominant clones that emerge after each line of therapy. We use, for example, one drug, and then we get rid of those clones that are sensitive to that drugs, but then a resistant clone can emerge and take over. So I think if we want to try to eradicate myeloma, we need to come up with a program that contains multiple drugs that will work on eradicating all the different clones within the patient. And we are learning that the immune environment within the bone marrow is suppressive, allowing myeloma cells to grow. So if there's a way that we can, awaken the immune system, maybe also help us eradicate myeloma. And this is you're familiar with the work started by Barloghi in Arkansas, the total therapy approach to managing multiple myeloma. It's an induction and consolidation, intensification, and then maintenance. If you're not a transplant eligible, it's a continuation of therapy. So for a long time, we had only the vincristine, adriamycin, dexamethasone, the VAD regimen, and then we had a stem cell transplant, and we either did nothing or give prednisone after a transplant. And you can look now at the number of sequences and number of combinations quite increase, and you can see some of these drugs now being used in the rescue being moved earlier on. And I'll try to share some of the data to suggest that we need to move some of these drugs earlier in the course of the disease if we're going to really cure myeloma. So the good news is that I think by introducing these drugs, we moved survival from being, for example, age above 65, only about 31% the 5-year survival, to 56% for younger patient from 63 to 73. And that's not really with the most novel agents that we have today. So I think the future is very promising. So what combination to use? I mean, this is a table of a lot of different combinations, just to highlight a couple of things, I think. For the first time now, we start seeing a larger number of patients achieving a complete remission and a very good partial response, more than 90% reduction in myeloma in a large number of patients, 68 to 86%. So that's quite important. And then progression-free survival and overall survival has translated, has improved based on that depth of response. So what I want to show you is, sort of how we walk through science and maybe walked, correctly or incorrectly. So in ECOG in America, we try to address whether, patient really didn't like high-dose dexamethasone, 40 milligrams for 4 days on, 4 days off, 12 days a month. So we said, okay, how about just let's do 1 day a week, the low-dose dexamethasone. And this was, 10 years ago or so. And what we tried to see, what is the response at 4 months, and see if we need to salvage. At that time, we had thalidomide, but I don't think anybody really needed thalidomide. So the first thing we learned is that definitely high-dose dexamethasone is superior in terms of the response and the depth of the response. You can see 79%, 42% over 68 and 24%. Clearly, more patients getting very good partial response. But we didn't appreciate initially, and we had to close the trial, is the treatment-related toxicity. In the first 4 months, we lost 5% of the patient on the high-dose dexamethasone versus 0.5%. So we kind of had to stop the high-dose dexamethasone arm, and by 3 years, the survival was matched in both groups at 75%. But we sort of forget how important response is, but we sort of did landmark analysis to see what happened to the patients when they get, the 4 months and survive it. Some patients stayed on the primary therapy, lenalidomide, dexamethasone. Some of them came off study and either did nothing or went to transplant. So the group that did nothing here had a 57% 3-year survival. So what happened to the people who had a transplant? The 3-year survival was about 92%. The people who stayed on their primary therapy was 79%. So this suggests maybe an induction followed by high-dose chemotherapy is superior to just continuation of therapy. But that was not really a randomized study. So what I'm going to show you is that it's important to get a very good partial response or CR because that translates to a superior probability of improving overall survival. And I'm going to share with you one of my patients who was on the study. So this guy was 50-year-old, had anemia, stage 2 disease, and normal cytogenetics. So he was enrolled on the high-dose dexamethasone. And what I want to show you is his IgA was 10,000 almost milligram per deciliter. And with lenalidomide high-dose dexamethasone, he had a rapid cytoreductions. You can see he dropped to 590 milligram per deciliter in 1 month. And he, by the time he went to high-dose cyclophosphamide for mobilization of stem cells and then high-dose melphalan, he was in remission. And this patient did not follow the Berloghi approach. He actually did not have any additional therapy since 2005. And look at his IgA. Is normal, his immunofixation is negative, he's still in remission, enjoying his retirement after being an engineer at Boeing. And the question is, he cured? Did he achieve a minimal residual disease? At that time, we did not have those assays. And now, once we have these assays, we probably should perform it to see why he's cured. So we showed that lenalidomide dex is great, is more better. Can we now improve on the response by adding 3 drugs versus 2 drugs? And so this is a SWOG study in America and looked at VRD versus RD, Velcade, Revlimid, dexamethasone. And what you see, first of all, is that the progression-free survival was in favor of the 3-drug regimen. Mind you that the dexamethasone now, everybody adopted the weekly schedule, the low-dose dexamethasone. And the overall survival was also superior in favor of using 3-drug regimen. So the question, is it good? And so in ECOG, we did another clinical trial, and it's still ongoing. And the questions in this trial, is lenalidomide, bortezomib, dexamethasone equal to carfilzomib, lenalidomide dexamethasone, CRD or KRD. So I'm going to show you a patient of mine who also had an IgA multiple myeloma. She was 59-year-old, had anemia, widespread bony disease. So she was stage 3 disease, intermediate risk cytogenetics, and she was enrolled on an ECOG, and she got the RVD regimen. This is the regimen that everybody now using in America for newly diagnosed patient. So what did she do? She did very well. Like the first patient, you can see she actually went down quickly in the first cycles and stayed with normal IgA for several months. So we had to do a bone marrow biopsy to document remission based on the clinical trial. And this is the bone marrow biopsy when her IgA was normal and immunofixation was negative. She had about 30% plasma cells remain in the bone marrow. She did not achieve a complete remission, and I didn't believe that. So I said, come back in 2 months, let's repeat your labs. So when she came back in 2 weeks, her lambda light chain, her kappa light chain was going up, and she was resistant to multiple lines of therapy, and we were able to salvage her with high-dose melphalan, modified dose at 140 milligram per meter square because she was on dialysis. So she responded very well, and now her kappa light chain is normal. So we saved her. Well, what happened is that a few months later, she started now developing multiple plasmacytoma. And then her kappa light chain went up, and unfortunately, she passed away. So unlike the first patients, this patient represents the difficult myeloma patient and highlight the clonal heterogeneity. If I was aware of this clonal heterogeneity, could I have done something better early on to try to eradicate these clones that caused the kidney failure and went on dialysis, and these clones that caused multiple plasmacytoma, CNS infiltration, and caused her to lose her battle? I think we need that. So the question, what she would should have been, if we gave her KRD, would her outcome be any better? So this is just to show you the initial presentation by Jacobiak on the role of carfilzomib, lenalidomide dexamethasone in a newly diagnosed patient. This is a complicated slide, but what I want to highlight is that this slide shows that there are patients who went on to transplant, and there are patients who just stayed on carfilzomib, lenalidomide dexamethasone. So we get an idea what happened if you get a KRD induction without transplant and KRD induction with transplant. And what you see here is quite very impressive. First of all, if you don't get a stem cell transplant, that's on the left side here, after 8 cycles, look at the depth of the response. 30% of the patient achieve stringent complete remission. And if the patients get a stem cell transplant after KRD, you're getting almost 69% stringent complete remission. Quite an incredible cytoreductions and response in a newly diagnosed patients, unheard of. More importantly, when we do minimal residual disease evaluation of these patients, whether we use it in the transplant or not transplant patient, whether we use a flow cytometry or next generation sequencing, you can see that the depth of response in patients who receive KRD and stem cell transplant, MRD negative 66% and 71% if they receive 18 cycles. So I hope NICE will see these slides and will change their mind about approving carfilzomib in this country, because I think it's a very powerful drug, it's a very important drug in helping patients with multiple myeloma. The ASPIRE studies clearly show superiority in using carfilzomib lenalidomide dex versus lenalidomide dex in the relapse setting. And why do we pay attention to minimal residual disease? Because I think, if you just get a partial response, the duration of, disease-free survival is quite short. And you can see, the deeper we get, the more myeloma cells we get rid of, the longer it takes to relapse. But more importantly, I think if we do get to undetectable minimal residual disease, hopefully that's when we start curing patients. So do we have any evidence to suggest that MRD is good for patients? There are a lot of trials now being published. So for example, if you look at patients who achieve CR, and they are elderly patients here on the left side. These elderly patients achieve CR and they stop treatment after 18 cycles of treatment. And if you achieve a minimal residual disease in the black versus the minimal residual disease positive in the red, clearly you can see a separation. Patients are doing better, surviving better when they achieve a minimal residual disease. Same thing if you look at patient who's younger, who get a CR after inductions and intensification and maintenance, and you can see that there are improvement in survival of the patients who achieve a minimal residual disease negative status. And it doesn't matter, seems, whether you get minimal residual disease through an induction treatment. This is the result from the French study where they looked at VRD, 4 cycles induction versus, and then either stem cell transplant or 2 cycles of VRD, and then 2 VRD consolidation and then maintenance. And you can see if you achieve an MRD, whether you get transplant or not, MRD translate to improvement in survival. So getting MRD doesn't matter how you get it, just getting it can improve your survival. And in this here, you can see that one-third of these patients who achieve MRD did not receive a stem cell transplant. 1/3. So getting an MRD is very important. So this is just a clone. This is a slide borrowed from Faith. And basically what it shows, it really sort of the idea, the impact of treatment on myeloma stem cells and maybe on the clones within the patient. So with each step, you actually sort of, to cure multiple myeloma, we need to deal with clonal diversity and maximize myeloma stem cell kills initially. Because if they sit there, they acquire additional cytogenetic abnormality that makes them very resistant. And so the impact of treatment, it's like the iceberg, yeah? You get rid of a lot of these, myeloma cells, but at the end you kept with small number of myeloma cells. So what does that mean to the patients? Basically what happened is that you may be ending up with the most resistant cells. And the maintenance therapy that we use today may not be the appropriate maintenance therapy. You need to address, the issue related to mutations, out of cycles, the microenvironment. We need to analyze that minimal residual disease in a comprehensive way so we can use the right maintenance so we can get rid of every last myeloma cells. And so designing the right treatment initially is very important. So I'm just going to highlight some of the newer sort of advances in the management of multiple myeloma just to show that we actually have an amazing drug today that we can use to help sort of overcome multiple myeloma. So you're very familiar with the slide, daratumumab, monoclonal antibody to CD38. And this is a single agent trial in patients who have seen multiple line of therapy. And what you see with single agent activity, a 31% overall response rate. Some of these are quite impressive. You have a CR, you have VGPR in 13% of the patient. So clearly a very powerful drug. And what's more impressive is that this is just to show you that when the patient responds, there's improvement in survival. But what's more impressive is that when you use it in combination with some of the active drugs we have. So this is a trial comparing daratumumab to lenalidomide dexamethasone versus lenalidomide dexamethasone. And clearly the progression-free survival is obvious, 83 versus 60% at 12 months and 78% versus 52%. If you combine it with bortezomib after one prior line of therapy, look at the combination of daratumumab, bortezomib, dex. Give it quite an impressive overall progression-free survival compared to bortezomib. So this is a drug that is right for combination because the lack of overlapping toxicity and because it's very active. How about the suppressive sort of microenvironment within the bone marrow? We talked about it, and there's a lot of different sort of factors that influence the suppressive microenvironment, and the PDL1 and PD1 pathways are very important. So this led to clinical trials that used the combination of checkpoint inhibitor in addition to lenalidomide dexamethasone. And the rationale was there is a preclinical work to suggest that you actually enhance the cytotoxic lymphocyte and T cells kill of myeloma cells when you use this combination. So this is a standard phase 1 study. And in this phase 1 study, there are a large number of patients needed to come off the study, 39 out of 77 patients. Most of it was for progressive disease, not because of side effect. But what's interesting here is that you get an overall response rate of 50%, and even in the refractory to lenalidomide patients, there was a 38% response. So we know that these checkpoint inhibitors on their own, they're not very active. So clearly, the combinations had interesting synergy and led to a nice overall response and some good, partial responses and CRs. So it's very interesting, and the question is, when do you use these kind of drugs in the management of multiple myeloma? That's just to show you that there were a lot of patients stayed on the treatment for a prolonged period of time, and the response sort of appeared at different parts. Some of it are quite early. So it's very interesting, early data. We need to wait to see what happened. How about elotuzumab? You all know that familiar with the elotuzumab story. It's unlike daratumumab, the single agent activity is quite low, but when you combine it with lenalidomide, you can enhance sort of the cytotoxic activity of the natural killer cells and T cells, bring them to the myeloma cells and induce myeloma kill. So this led to this clinical trial called ELOQUENT, where elotuzumab combined to lenalidomide and then compared to lenalidomide dexamethasone. And the primary endpoint was progression-free survival. So what you see in this trial is that clearly the median progression-free survival was in favor of the combination. The overall response rate was superior, and there were slightly more very good partial response. The side effect was quite limited, and so it's a very interesting drug that is very promising. The question is, where do you put this drug? We're still struggling, but I think this drug may be useful at the time when you have small volume disease, you're trying to bring the immune system to help you eradicate myeloma. I think if you have a very aggressive disease, I'm not sure the combination can be as effective. You all heard about the CAR T cells. I think the problem with the CAR T cells is what is the right antigen to use. And the initial CAR T cells was using CD19, and we all know that CD19 is not the most common antigen on myeloma cells. But despite that, this is sort of the patient that got a lot of publicity in the US. It's a lady who had IgA myeloma and had multiple line of therapy. You can see everything in the book. Despite that, she had a very aggressive disease, and she started relapsing on the right upper side. And what you can see, she got cytoreductions with cyclophosphamide. Then these cells were produced in the lab, and then when they were ready, she got melphalan 140, and then she got the CAR T cells against CD19. And what you see here is that she got a very nice cytoreductions, the IgA normalized, and the bone marrow on the bottom that was full of myeloma cells became empty of myeloma. So she achieved a complete remission. Not sure that's lasting, and unfortunately, not every patient on the trial did as well as this patient. And a couple of things that are problematic with this approach is, number one, is the CD19 is not present on all myeloma cells, maybe on some of the myeloma stem cells, but also the cytokine release syndrome that can be very aggressive and very difficult to treat. So I think some of the alternative to CD19 is using the B-cell maturation antigen. And so this is another approach that was started at the NIH, National Institute of Health, presented at ASH last year. And this was a classic phase 1 dose escalations. So in this phase 1 dose escalations, there were, one patient achieved a stringent complete remission, one patient a very good partial response and 2 partial response. So it's a very promising approach to manipulating the patient's T cells to attack antigens on the surface of myeloma cells. But I think the most exciting thing today in my mind is these sort of BiTE, where you get these generated molecules that contain CD3 receptors, B-cell maturation antigen and cytotoxic granule, and you can bring the T cells and the myeloma cells together and lead to sort of myeloma cell kill. This is work Amgen is a leader on that. I'm very excited about such an approach because it's maybe less complicated than the CAR T cells. So the path to cure, I think, require validated minimal residual disease assessment and inclusion of those in response criteria. I think clonal heterogeneity and epigenetics need to be assessed and addressed at time of treatment selection. And this may explain the clonal dominance at different stages when you use sort of single class approach. We need to build a treatment program that can eradicate the clonal heterogeneity and produce lasting negative minimal residual disease. And finally, I think we need to sort of improve the immune surveillance. So I'm not like, what's his name, Trump, who tweets all the time and millions of people follow his tweet. I just had 6 people like my tweet at ASH last year. And I said, this is the formula to cure. You give DKRD times 4 plus transplant, and then you give DKRD times 2, and then you do EP times 12, and that should equal cure. So what I'm doing is an induction with daratumumab, carfilzomib, lenalidomide dex, give the transplant, consolidate with a similar regimen, and then 12 months of eltuzumab, pomalidomide, to try to enhance the immune system and eradicate residual disease. So I'm glad my colleague, Rafael Fonseca, said, what looks like complex algebra holds cure. So hopefully we can do the right trials and maybe together to cure multiple myeloma. Thank you so much.